الرحيم والصلاة والسلام على رسول الله الكريم سيدنا محمد وعلى آله وصحبه الطاهرين. We are in Tabab Advanced Learning Center. We are so blessed to be with you this evening, and this session that was prepared and will be presented inshallah by Dr. Imad Hassan, titled Hypertensive Patient Smart Decision Making in Acute Medicine or Case of Acute Medicine. This is the last session in our series اللي هي امتدت خلال الأسبوع الماضي 4 sessions وحتتكرر ثاني إن شاء الله. I'm Dr. تيسير كاشف, Director of Tabab Advanced Learning Center, and I would like to welcome you again. دكتور عماد صلاح هو أحد مؤسسي الطبابة and graduated from the University of Khartoum and has acquired a medical doctorate from the University of London, UK in the year 2000, and is a fellow of the American College of Physicians and the Royal College of Physicians of Ireland. Highly qualified and experienced clinical and academic consultant physician with an outstanding track record in hospital-based patient care and academic training of clinical staff and undergraduates. He has chaired many academic committees, including competency-based medical education and knowledge translation, that is implementation of evidence committees. Before we start, please make sure وصايا العشرة that you mute your mics. Dr. Imad, we are so honored to be with you this evening in your abundant knowledge and experience, and thank you for giving us this opportunity in your valuable lecture series. Thank you so much. تفضل دكتور عماد مشكورا.
مشكور دكتور تيسير والاخت ريان, بارك الله فيكم, مشكورين الحضور والحقيقه والبروفيسورز اللي معنا. I was wishing that I will have more people actually trainees, junior staff with us, but there are not so many. فمشكورين كثير على حضوركم. I hope that this talk, I'm actually confident this talk actually will be a good one for, especially for Dr. Fattah and Dr. Nusayba, because they really need these things. فبارك الله فيكم, ونبدأ نقول بسم الله الرحمن الرحيم. معلش أنا I cannot do screen sharing. The host disabled participant screen sharing.
Okay, Prof.
طيب, بسم الله الرحمن الرحيم. My talk today is about decision making in acute medicine, and I'm actually going to share this with you in, practically using actually a true case which was presented in one of the morning meetings with the Department of Medicine at King Abdulaziz Medical City, the National Guard in Riyadh. Okay, decision making actually takes a lot of our time. As a matter of fact, when it was quantitated, they found that actually most of the time in our work, when we are working, almost 80 to 90% of our time is actually about decision making. So it's a very important issue. We know that, you know, experts in clinical medicine decide using 2 ways. One is called using cognitive schemes, أو الخرائط الذهنية, and the other one is actually using something called the illness scripts. Illness scripts actually is based on previous exposure. They have seen the case before, they just quickly diagnose it, okay, and they know how to manage it. This is called an illness script. But the way that actually, until our juniors acquire these illness scripts by seeing more and more patients, they have to rely on cognitive schemes actually to make the right decisions. A simple cognitive scheme, which everybody in medicine knows about, is that when somebody comes in with acute renal failure, and you actually straight away, you know, decide is it pre-renal, renal, or post-renal. A simple cognitive scheme that's been used by all disciplines in healthcare, in medicine. So it's all about actually achieving excellence in decision making and making the right decisions from good to great. Right, and as I mentioned, this is actually a true case. Now, there is one simple objective, is actually that once you've actually seen this case and how it is being managed, you actually articulate a comprehensive management input for any acute medical case, using cognitive schemes and using the map that I'm going to explain in a minute. Right, there are actually 7 golden steps, which every clinical case has, you know, every practitioner has to go through whenever they are actually faced with an acute medical case. Okay, now a true case came to us in the Department of Medicine. She's a 64-year-old female. She's a known case of diabetes, hypertension, dyslipidemia, and bronchial asthma. And you can see this, the diabetes, hypertension, dyslipidemia. This is a common, actually, denominator in many of our cases in Saudi Arabia. She's also having bronchial asthma and was known to have uncomplicated cholelithiasis. The patient is following with the pulmonary service regarding her asthma with possible query and associated bronchiectasis. And bronchiectasis in asthma is usually a complication of long-term, uncontrolled asthma. So asthma was labeled as difficult to control, requiring many hospital admissions. As a matter of fact, she's frequently in the hospital or in the ER. In the pulmonology clinic, right, she came with a regular follow-up, but in the clinic, they have noticed that she was hypotensive, that she was rather drowsy, she had reduced level of consciousness, and the family are saying that she's not as coherent and communicating as usual, and they said that she's sleeping more than usual. And in the clinic, obviously, because she's a diabetic patient, they checked the glucose level first thing, and it was fine, right? And these were actually her parameters in the clinic. She was hypotensive with a 88 systolic, 43 diastolic, with a mean of 55, and obviously we want the mean to be above 60. Right, her heart rate, she was not very tachycardic. Her respiratory rate was around 20. She was afebrile. She was saturating 93%, and this is on room air. The team in the pulmonary clinic just straight away sent her to the ER. Now, what happened in the ER, right? Now, the history the ER physicians documented was that for the last 2 weeks, the patient is having altered level of consciousness, which was associated with drowsiness and confusion, and there is a clear decrease in oral intake, right? The day before admission or before seen in the clinic, her symptoms are actually getting worse, and the patient started to having episodes of vomiting, and the family said she had vomited at least twice, but they didn't notice any blood or coffee grounds, right? The other negatives in the history were that there was no chest pain or palpitations, there was no diarrhea, no urinary symptoms, no weight loss, no fever or sweat, and she didn't come into contact with any sick patient, over the last few weeks or few days. Right? She had, in the past history, some multiple ER visits and admissions due to poorly controlled asthma, and the patient is not actually compliant to her medications. She never had any surgery, no recent travel, no known allergies. She is a non-smoker, and she lives with her son. These are her medications. She was on salbutamol inhaler and seretide, tiotropium. So salbutamol is a beta-2 agonist. Seretide is a LABA steroid combination. Tiotropium is a LAMA, or a long-acting anticholinergic drug, usually given for people with difficult to control asthma or COPD. She's on montelukast, which is a leukotriene antagonist. She's on candesartan, an angiotensin II blocker for hypertension. She's on a long-acting insulin, glargine, and omeprazole for other PPI treatment for her to protect the stomach. When she was examined, these are the same vital signs, which were again documented, but the patient was drowsy and not in pain and not jaundice or pale. They could hear the breath sounds bilaterally, so there was no element of possible pneumothorax in a difficult to control asthma patient and complicating asthma, and she had bilateral wheezing and some scattered crackles. Her abdomen was soft and lax and tender, no organomegaly. The cardiovascular system was, heart sounds were normal, and no lower lymphedema, no palpable lymph nodes. They could not actually assess her neurologically very well because they were difficult to communicate with. And there was no rash or joint swelling and no nerve clubbing. Right. Now, when we actually see a patient like this in ER or the acute case of medicine, right? We don't tend to go systematically to actually unravel what is going on with the patient. We actually tend to jump from one to the other, right? Most actually, and when I teach the juniors in the morning meeting, most actually miss one or two of these important 7 steps, right? They usually miss one or two of them. It's unbelievable, but this is the true. This is truly what happens, right? When they gather the information, according to evidence-based literature, the history and physical examination should be both patient-centered and hypothesis-driven. So the history and physical exam, both of them should be patient-centered and hypothesis-driven. Patient-centered means that I am not only interested in knowing the disease or what's wrong with the patient, but I'm also interested in knowing the illness, what's the impact of the disease on the patient's well-being, whether it's social or psychological or financial or whatever. So it has to be patient-centered. And it should also be hypothesis-driven. If the patient is actually sent to us with a hypotension, right, I should actually have in mind what are the points in the history and in the exam I should focus on to find the diagnosis. So these two components have to be included in the history. The second part, which is again not very well done by junior doctors, is actually coming up with a technical language summary. And actually studies in decision making have found that actually doctors who are able to verbalize a technical summary, a top-class technical summary, do better in their decision-making and management plans. So ability to summarize properly is not a luxury. It's actually an important element in the care of acute patients, right? People have to come with a comprehensive diagnostic label. Now, this comprehensiveness is very important. Now, most of the time, right, people will tell them, oh, so what's wrong with this patient? They say she has hypertension. Well, you ask them, what's wrong with this patient? They say the patient has heart failure. They don't actually appreciate that heart failure or hypertension are not diagnoses, but that's a manifestation of something else. So they don't actually say the patient has heart failure because of an acute coronary syndrome, or the patient has asthma because of an infective exacerbation. So the people actually fail to provide a comprehensive diagnostic label. An important element they miss when they put their diagnostic labeling is they don't actually put a comprehensive problem list. And this was found to be an important element of why people have an incomplete management of their patients. Unless they put a problem list day one, they don't look at this, and they might actually fail to see them until the patient is actually ready to go home, and it delays their discharge. Believe it or not, the majority of actually our junior residents don't try to put a good differential diagnosis with their pros and cons. They say, okay, this is the diagnosis. They start treating, doing the tests and start the management, right? They don't put a differential diagnosis. And this was found to be an important component of missing, an important reason why people miss the other diagnoses, right? Because they don't put a differential diagnosis, they don't do the right test for these differential diagnoses, and therefore they miss the diagnosis, right? And obviously, people have to do the test rationally. You know, you're not supposed to do just all the tests, but you do it rationally based on sensitivity, specificity, and likelihood ratios. And this is an important concept which, unfortunately, few clinicians appreciate because these are actually not taught routinely. And some people have to attend an EBM course, evidence-based medicine course, actually, to understand what is meant by sensitivity, specificity, and likelihood ratios, right? But we should use tests according to the sensitivity, specificity, and likelihood ratios. And then ordering the immediate therapeutic interventions, right? And we have done actually a study on this, and we found that the majority of our doctors actually miss one or two components of the important immediate therapeutic interventions. It is sad, but it is true. And then obviously we want to prepare for discharge, and people in good medical practice in hospitals, especially people in quality, they will tell you that you prepare for discharge starting on the day of admission. So you don't prepare for discharge, you know, on the day of discharge. You start preparing on the day of admission. So these are called the 7 golden steps. And I'll just briefly actually mention, right, some of the schemes actually, or some of the schemes that are used, the cognitive schemes that are used actually in doing this. For example, when you articulate a comprehensive diagnostic label, you have to include three things. And this is what guidelines are saying. You have to include your bedside diagnosis, etiology, and severity. If you have somebody with an acute coronary syndrome, you have to say, and he's coming with heart failure. So you say that patient is actually coming with acute heart failure, the etiology is acute coronary syndrome, and the severity is CLIP class 3 or CLIP class 4 or whatever, right? Every patient has to have the etiology and severity score in the diagnostic label. And as a matter of fact, all guidelines then tell you the management depends on the etiology and the severity. Somebody with community-acquired pneumonia due to coronavirus, and the severity is actually, you can use the CARB 65 for community-acquired pneumonia severity scoring. And then the management actually depends on the etiology and the severity scoring. But if I say the patient has only got community-acquired pneumonia, right, and I kept quiet and I said that's all, then I have not put the etiology like coronavirus, and I have not put severity like a CARB 65. The etiology dictates what medications I should use, for example, steroids, shall I use steroids or not? And the severity tells me where to put the patient. If they are CARB 65 is 4 or 5, then these patients have to go to the ICU, right? So the comprehensive diagnostic label has three components: the bedside etiology, the bedside diagnosis, etiology, and severity. And I have seen it every time. Whenever we've done the morning meeting, you tell them, okay, what's the diagnosis? It's bronchial asthma exacerbation. What's the diagnosis? Is acute heart failure. What's the diagnosis? Acute stroke. But what is, you have to give me a comprehensive label. And actually, these are the schemes that the good diagnosticians, good clinical diagnosticians use. They use something called pattern recognition. The simplest thing is, you recognize the pattern in an ECG and say, this is an acute myocardial infarction, acute anterior myocardial infarction, okay? This is called pattern recognition. You see somebody with, with acromegaly, you say, this is acromegaly. So this is pattern recognition, right? So pattern recognition is an important diagnostic skill. The second one is, there are three R's. There are these three R's. Now these three R's are the top class expertise actually for ER doctors. They rule out the rule of thumb. Rule of thumb means if somebody is coming to me with a morning headache and vomiting, right? The rule of thumb says maybe he has intracranial, increase in intracranial pressure. So this is the rule of thumb, right? A rule of thumb is coming, a patient actually who comes in with a smoker, middle age, coming with a central chest pain radiating to the left shoulder and with sweating and vomiting. The rule of thumb says this is acute MI, acute coronary syndrome. The second R is called ROAD, ruling out the worst case scenario. If somebody is coming to me with central chest pain, my first differential diagnosis would not be severe spasm. My first differential diagnosis is acute coronary syndrome. So another cognitive scheme, ruling out the worst case scenario. And then the red flags. A red flag means there are symptoms or signs suggesting a serious pathology. If somebody is coming to me with back pain and they have lost weight, and then this is a red flag. Losing weight in somebody with back pain, this is a red flag. Somebody with back pain and having actually a weakness in the leg, this is a red flag. And actually, good decision makers in medicine use these things: pattern recognition, rule of thumb, ruling out worst case scenarios, and red flags, so that they don't miss their diagnosis. And these are important schemes that actually all of our doctors should know about. And then the fourth scheme is when you ask them to put a differential diagnosis. And most actually doctors, again, when they do not have a scheme, they come up with something. They say somebody is coming in with community-acquired pneumonia, right? And they say maybe it's coronavirus, maybe it's the pneumococcus, maybe it's mycoplasma, right? But they do not have a good scheme to build on. And if you have a good scheme just like that, you are unlikely to miss anything important, right? And the scheme in medicine, there are only three schemes for differential diagnosis, only three schemes: anatomical, physiological, and pathological. And I'll share that with you shortly. And then you order the test rationally. A very simple tool in assessing, if I want to do a specific test, I need to know the probability. Because if the probability is high, I will use a screening test. I will use a specific test. If the probability is low, I will use a screening test. Just to give an example. Now, the D-dimer test is a test for DVT and thromboembolism. Now, if the probability is low, I will do the D-dimer. But if the probability is high, I will not do the D-dimer. I will go for example, a spiral or a CT pulmonary angiogram. Okay? Why? Because the D-dimer is considered a highly sensitive test. Highly sensitive tests are screening tests when the probability is low. So the same thing for the brain natriuretic peptide. It's a screening test. It's a highly sensitive test. It's not specific. There are so many reasons which can increase the BMP or the D-dimer, right? Or the C-reactive protein. Now, or the white count and whatever. These are all called sensitive tests, right? And I would not know whether I should use a screening test, right, or a specific test, unless I know the probability. And so you ask the doctor, okay, which test are you going to do? It is very unusual to find the resident saying that I need to do probability assessment before I decide on what is the test I should do, right? They are not very good in deciding the probability, and therefore they cannot decide very well, should I use a sensitive test or a specific test? A sensitive test like the D-dimer and the BMP and the CRP and the white count, right? These are sensitive tests. It means that they can be positive in so many reasons, okay? It's not only heart failure that increases the BMP. It's the only infection that increases the CRP, okay? It's not only thrombosis that increases the D-dimer. There are so many other causes. That's called sensitive tests, because they can actually be positive even in with other diagnoses, right? A specific test means that the test is actually diagnostic. A specific test is diagnostic. So when a patient has a high probability, right, I will say, okay, I'm going to do the specific test. But if the patient is actually low probability, I will use a screening test or a sensitive test, right? And then the immediate therapeutic interventions. And now this is another issue, right? You tell the resident or the trainee, okay, how are you going to immediately, the unusual thing is that they will come up with the 5 important things, which are called the 5 S's. And then preparing for discharge. And again, you ask the resident or trainee, how are you going to prepare for discharge for your patient? And the reason that, they do not know actually how to do it. Now, I'm going actually to go through all this using this specific case that I'm sharing with you, okay? Now, just to emphasize the AP scheme, the AP scheme actually says that there are 2 ways of assessing probability. We have 2 ways of assessing probability by evidence. One is called the AP scheme, which is A stands for absent, A for absent. There is no alternative plausible bedside diagnosis. For example, you say somebody is coming in with pleuritic chest pain and breathlessness, and you do an X-ray and it's normal, plausible bedside diagnosis. But if I find that he had a pneumothorax or a pneumonia, I can say there is an alternative diagnosis there. So it makes PE unlikely, right? But A stands for an absent alternative and B presents a strong risk factor. So if in that particular patient with pleurisy and breathlessness, right, and I find that the X-ray is normal, so there's no alternative plausible bedside diagnosis, but had a strong risk factor. For example, he had a recent fracture, right? So both are positive. Absence, there is no alternative diagnosis, and there is a strong risk factor. This is a high probability. And believe it or not, the British Thoracic Society came up with the AP scheme, for more than 20 years. A very simple scheme of assessing probability, right? And if the probability is high, you go for a specific test, as similarly for intermediate. But if the probability is low, then you go for a screening test. It's a D-dimer or a BMP or a CRP or whatever, right? And the other way that actually evidence-based probability assessment is using scoring tools. For example, the Wells score, right? The Duckett-Jones criteria. They use, for example, for assessing the diagnosis, the Alvarado score for acute appendicitis. These are all actually scoring tools to help you make the diagnosis. And so we can assess the probability before doing the test by two simple ways. One is called the AP scheme, and the other one is obviously the scoring tool. And then the 5 S's that I keep telling the residents, come on, when you are actually treating a patient, make sure that you have covered all the 5 S's, that you have decided the site of care, that you have given symptomatic treatment, for example, analgesics, that you have given supportive care like IV fluids. So what's the difference between symptomatic and supportive? Now, symptomatic is the symptoms that the patient came in with. Now, this patient, for example, came in with vomiting, right? The symptomatic treatment, well, I have to give an antiemetic. That's the reason she came in with, right? Patient who came in with a headache or any pain, I have to give analgesia. Patient coming in with fever, I have to give an antipyretic. So symptomatic. Supportive is the intervention that you use to actually control the abnormal physiology until the patient gets better. For example, if a patient actually is coming in with severe diarrhea and shock, right? And the diarrhea due to salmonella, I could give him, anti-salmonella treatment from now to 100 years, and he will die before I give him supportive care. So supportive care is sometimes much more important than the specific care. Supportive care is, for example, dehydration, you give IV fluids. Hyperkalemia, you correct the hyperkalemia. These are called hypoxia, you correct the oxygen, right? These are called supportive interventions to reverse the abnormal physiology before the patient actually succumbs to their illness. And obviously, specific is somebody coming with acute coronary syndrome, you might use thrombolytic intervention. In medicine, in modern medicine, there is nothing called you treat a patient on your own. Every patient needs multidisciplinary. So these are the 5 S's, the scheme for immediate interventions. We train our people, right? We train our people to do. Now, in this particular patient, is the history patient-centered? As a matter of fact, there was nothing in the history to tell about the impact of the disease on the patient. Has she stopped looking after herself, right? Was she able to feed herself? Was she able to go to the toilet, right? If it's a man, has he been able to go to work? Or a student, has he been able to go to school or university, right? Now, is the examination hypothesis driven? As a matter of fact, it's the same thing. Even the examination was not completely hypothesis driven. In the history, yes, they have asked about symptoms of infection like fever. They asked about chest pain because she's hypertensive and diabetic and dyslipidemic. Maybe she had an acute MI, right? They asked about these, right? They asked about diarrhea and vomiting. And diarrhea, for example, she might be losing, right? But they have not asked about everything about other hypotheses. So the history, as a matter of fact, which was brought up in the meeting, was that the history was not patient-centered and was not hypothesis-driven. And this is to emphasize that whenever we are actually dealing with a patient, we have to focus on both the disease and the illness. The disease is the diagnosis we are interested in. The illness is the impact of the disease on the patient, right? And we have to deal with both the disease and the illness, right? Patient-centered, patient-family-centered, we focus on the disease and its impact on the patient and family. And hypothesis-driven, we focus on symptoms and signs relevant to the suspected diagnosis, right? Examples would be, did your illness stop you from doing something you regularly love to do? If you suspect Legionnaires, have you been traveling abroad recently or staying in a hotel, right? So the history has to be patient-centered and hypothesis-driven, okay? Our patients actually want to make sure that you know what's their disease, their illness, and they want you to be actually very professional and having good communication skills with them. Right. Coming back to the steps, the second step, because the first step is history and physical, right? The second step is about summarizing it. Now, this is actually needs training. You know, unfortunately, our juniors need to be trained on how to summarize, right? They would actually say on examination, the patient's pulse rate was 130. No, but when you give a technical summary, you don't say the pulse rate again. You just come up with the conclusion, right? That the patient was tachycardic. If you're on examination, you found that there is shifting dumbness. When you put the summary, you say the patient has ascites. If the patient has late fine beta crackers and a cardiac patient, you don't come and say in the summary that he had late fine beta crackers, but say patient has pulmonary edema, and so forth. This is a skill which, unless the juniors are are trained to actually give the right way of summarizing, and as I said, by research, they found that the, better doctor decision is actually seen in people who actually are able to make better summaries. Okay, now the technical or expert summary in this particular patient, although doesn't have the psychosocial impact because this was not asked about at all, right? About the illness, that she's an 84-year-old, it's actually 64, excuse me, the mistake here, is a known case of hypertension, diabetes, dyslipidemia, poorly controlled bronchial asthma with frequent ER visits and admissions, uncomplicated cholelithiasis, and GERD. She presented with a 2 weeks history of worsening level of consciousness, somnolence because she was sleeping a lot. I don't write here that she was sleeping a lot. I will write the technical term, somnolence. Reduced oral intake and vomiting. On examination, she was drowsy. Obviously, it's better to put a Glasgow Coma scale if I know, right? And she was uncooperative. That's why they couldn't actually examine her neurologically. She was afebrile. I don't write the temperature, but I will say she's afebrile. And she was hypotensive, right? So this is the technical or expert summary. And then comes the second part, the diagnostic label. And as I mentioned earlier, the diagnostic label has to come 3 parts, right? Now, one has to say the bedside diagnosis, the probable etiology, and the severity, so that you want to decide, is it an urgency, which I can maybe take a few hours or a few days to manage, or it's an emergency, means that if I don't interfere now, within the next few minutes, the patient is going to die, right? So it's very important that I come up with all the 3. Now, this bedside diagnosis in this patient, you can call it hypotension, right? And the etiology, because you don't have many clues there from the history and examination, right? Maybe she has drug-related disease because she's candidatal. And is it an emergency? It's probably yes, because she's not only is she hypotensive, but also she has change in sensorium. You see, a change in sensorium is a red flag by itself. So this makes it an emergency. You know, the level of consciousness is low. Okay, so this makes it an emergency. So now I made the diagnosis, bedside diagnosis, etiology, and severity. But if I now said that I have put the diagnosis complete, I have actually missed actually an important element, right? Now, this lady has all these medical problems. If I do not actually articulate them and write them and list them at the beginning of my interaction with this particular patient, and I put my plan for this as well as the others, right? Then I'm going to be giving an incomplete input. Okay, so these are very important. Not only that, she has gallstones. Maybe she has pancreatitis. Maybe she developed gallstone pancreatitis. She's diabetic. Maybe she had diabetic ketoacidosis, right? It's important that I put these and articulate in my mind, you know, their implications and the way I need to manage them, right? And so I have in front of me a hypotensive patient. This is a patient who's hypotensive, right? Somebody might say, well, is it hypotension or shock, right? Now, shock actually, you need more data to say that she has shock. You want evidence of real end organ hypoperfusion and hypoxygenation. So now, for now, I can call it a hypotensive patient rather than a shocked patient, okay? Right, now, this is the scheme for the differential diagnosis. And you can see there are ways of putting the differential diagnosis, the anatomical, physiological, and etiopathological. And these people actually have to be trained on how to use them, right? Now, for people with shock or hypotension, they say the differential diagnosis should be physiological differential diagnosis. The scheme used for patients who are in shock, they're actually, it's a physiological differential diagnosis. Is it hypovolemic, distributive, obstructive, or cardiogenic? And when we actually discussed this case in the morning meeting, right, very few actually of our trainees were able to come up with this differential diagnosis because they were not aware of the right scheme to use, right? They were just going, maybe she has hemorrhage, maybe she has sepsis. They were not actually putting it in a scheme, right? And if you put it in a scheme, you are unlikely to miss important ones, right? Now, as a matter of fact, this was a differential for this lady. We don't have any labs yet, right? Hypovolemic, distributional, cardiogenic, and obstructive, right? Who is warm and who's cold, right? All of them are really would be actually cold, except maybe distributional, specifically with septic shock. You know, distributional is septic shock and because of vasodilatation, right? And these people would probably be warm, you know, that's why they call it the warm shock. But all the others are likely to be cold, right? So you can actually hint that this lady was actually warm, right? Probably warm. So it's probably distributional because she was warm. There was no comment that she was cold. So just from the examination, I would say probably she had distributional. And there is something else, what is called the rush protocol, right? Now, this is something which we brought up actually in the meeting. Now, let's just remind people of what are these 4 categories of shock, right? One is hypovolemic and the other one is distributive. And the classic distributive one is actually a patient with sepsis. They have distributive shock, sepsis or anaphylaxis, people with adrenal insufficiency or hypocortisolism, because the steroids are important in actually maintaining the vascular tone and sensitizing it to the epinephrine, right? So they have vasodilatation, people who have a neurogenic shock because of spinal cord injury, for example, or people who are on drugs which are vasodilators. Cardiogenic, obviously, these are acute coronary syndromes and myocarditis. Now, the 4th category, which actually many patients, actually many of our trainees tend to miss, is pulmonary, like massive embolism, tension pneumothorax, O2PIP intubated cardiac tamponade, and a very interesting entity called the abdominal compartment syndrome, right? These are called the obstructive types and the obstructive shocks. And unless you have these in mind, you are not going to do the right test because you're going to miss the important test for each, okay? And there is something called the rush protocol, which is rapid ultrasound in shock protocol. Now, people are now using the, the point of care ultrasound. It's called POCUS, point of care ultrasound. You see the butterfly IQ, which is, connected to your iPhone, and you can do it at the bedside in the ER, and this is going to replace our stethoscope in the near future, right? And using this rapid ultrasound in shock protocol, you can, by the bedside, differentiate, are you dealing with cardiogenic, hypovolemic, or obstructive shock, right? And obviously now that I have a differential diagnosis, right, and I can do some probability assessment. Now, absence of an alternative diagnosis and presence of a risk factor. Now, this particular lady, if I was looking at at her background, the past history, they're all relevant. But as I said, I probably would, focus on the distributional because she was not cold. That this is probably distributional. So it is sepsis or other vasodilatation. Now, the list of tests for hypovolemic, distributional, cardiogenic, and obstructive are quite a few. As a matter of fact, there are actually ordered sets for patients with shock, right? In this particular patient, because she's diabetic, I'll be worried about diabetic ketoacidosis because of, because she's diabetic. She had a glucose level which is normal, or normalish, but we shouldn't forget that there is a form of ketoacidosis which is called euglycemic ketoacidosis when patient's glucose is not very high, right? So I need to do more tests for hypovolemia, distributional, cardiogenic, or obstructive, depending on my probability assessment and available resources, right? Now, I don't need to wait for these tests. I can immediately start with management for this lady, right? Because the first 3 S's in patient care, in management, are actually don't need any labs, right? I can decide on site of care. This lady, as she's level of consciousness is low and she is hypotensive or shocked, she possibly needs to go to the ICU. I can give her an antiemetic, and I can start some IV fluids, boluses of normal saline until I actually find out what's wrong with her, okay? So I don't need to wait, until I get the labs before I start my management. And this is actually what good doctors do in the ER. Now let's together look at the labs, and now it will become very interesting, okay? Now look at the sodium level. Now she had a sodium level of 111, right? This is a serious hyponatremia, right? You can straight away see that the potassium is maintained. The BUN creatinine are not that bad, so she's not really dehydrated. She doesn't have a major dehydration, okay? Her sugar is fine, and her bicarbonate is fine, so she doesn't have ketoacidosis. She doesn't have ketoacidosis. She doesn't look like she's dehydrated, right? Potassium is probably maintained, and sodium is critically low, right? The combination of actually highish or tending towards high potassium and a lowish sodium, this labels the patient as probably going into what we call the hypoadrenal pattern, which goes with adrenal insufficiency. So this is the hypoadrenal pattern, okay? Now, is it drug related? Is it something else? But the major concern is when I find a very low sodium and relatively maintained or highish potassium, is actually to think, oh, this is a hypoadrenal pattern. She's a bit anemic. The white count is again normal, right? Her platelets are not increased to suggest, for example, bleeding, hemorrhage, right? More interesting data. Now the serum osmolality was low. So she had a hypotonic hyponatremia, right? Her CPK is low also, suggesting that she probably has very little muscle mass. Her BNP is also low, so this makes a cardiogenic cause unlikely, BNP and pro-BNP, although I need to know the BMI to make sure it's not falsely low because the patient is obese. She's not in lactic acidosis, right? The LFT is fine, TSH is fine, cortisol level is actually a random cortisol level was quite low, right? Doesn't make me 100% sure she has adrenal insufficiency, but it supports my probable diagnosis that what she has got is a distributional. Doesn't look like sepsis. She didn't have any drug to cause anaphylaxis. She is on candesatan, whether that has anything to do with it. Now the urine sodium is high. So she doesn't have depletional hyponatremia. So any reading above 20, yeah, suggests a high urine sodium, so it's not depletional. She's not actually sodium depleted. And the urine osmolality is reasonable, so she's able to concentrate the urine. So now I can tell that she had a hypotonic hyponatremia with increased urinary sodium and a low cortisol. I can straight away see that I'm now going towards a specific diagnosis. She doesn't have ketones in the urine, okay, so she doesn't have diabetic ketoacidosis, okay. Now, because they actually were worried about obstructive shock because she has been in bed for 2 weeks, right? They did a chest angio, and this was negative. There is no pulmonary embolism, but interestingly, it has shown that she has osteoporotic compression fractures, T8, T10, and T12, and this is obviously the result of using too much steroids, right? And her X-ray looked like a dirty X-ray, and this is typical of people with long chronic asthma, right? Poorly controlled. You can see that the lungs do not look healthy at all, right? There are some interstitial changes. There is some opacification in the right base, which has been actually there for many years. I could still see the hemidiaphragms, so there doesn't seem to be a major consolidation, obscuring, or heart failure in this lady, right? But her X-ray doesn't look healthy at all. Right, because of her reduced level of consciousness, she had a brain CT, which didn't show much, right? And so what's the next step? Now I have a lady who is hypotensive, critical hyponatremia, hypotonic hyponatremia, and at the same time, she has increased urinary sodium and a cortisol level on the low side. So what is my next step? Obviously, this talk should be interactive, and that's why we're actually doing it. We actually do it with the audience around, right? So, but obviously, unfortunately, we cannot do it now. Now, this lady was started on 3% hypertonic saline, 20 mils an hour for 3 hours, right? And starting with a very low dose of 3% hypertonic saline, because this lady's hyponatremia is probably chronic. So if you correct it very fast, without you give too much hypertonic saline at a higher rate, right, you might end up with osmotic demyelination or central pontine myelolysis. So this patient has chronic hypotonic hyponatremia, and so you need controlled sodium correction. So they are starting with a very low dose of 3% hypertonic saline, 20 mils in the ICU using a central line. They were doing the sodium levels every 2 hours, right? And they actually put a parameter that we need to go a maximum of 10 increase of sodium from 111 to 119 in the first 24 hours. 121 in the first 24 hours, the maximum. They consulted the endocrine service because they felt that this lady has hypoadrenalism, right? And they did the Synaxin test. The Synaxin test or cosinotropin test, it stands for synthetic ACTH or engineered ACTH, and they did the Synaxin test. And surprise, surprise, right? The baseline cortisol was again on the low side, 90. 60 minutes, it only increased to 390 nanomoles. And the normal range is, the normal response is that it should go above 500 or 80 micrograms per deciliter to say that this patient has a normal response from the adrenals. So it was clear that this patient's adrenal glands are gone and they have now atrophied and they're not working, right? So the patient actually was labeled as acute adrenal crisis and she started on stress doses of steroids, right? Right? That's the usual way we treat with cortisone, hydrocortisone, or prednisolone. Some people prefer prednisolone because it's once a day, 2.5 milligrams. But some people, even at this low dose of prednisolone, they can develop some steroid side effects, right? Now, this lady, the question came up in the morning meeting when we were holding the meeting, whether this lady should have been offered steroids even before completing the before doing the Synaxin test. The simple answer was yes. That patient should have been offered steroids in ER even before doing the Synaxin test, okay? Because she was hypotensive, severely hyponatremic. Now, there are rules for offering steroids to patients in the ER, right? You have to offer it to all patients if they're critically ill and hypotensive, right? You just give it. Patient who has confirmed hypoadrenalism and hypopituitarism, you just start them on steroids when they come into the ER, the stress dose. Patient who has, signs of Addison like skin crease and buccal hyperpigmentation. Patient with vitiligo and other autoimmune disease. If somebody comes to me in the hospital, they have Hashimoto's thyroiditis, they have vitiligo, or they have pernicious anemia and they're hypotensive, I will probably start them on steroids, because these are all autoimmune diseases which come together, right? Obviously, if I see that the patient has been on chronic steroids like cushingoid phase or skin purpura, then I will just give them. As a matter of fact, in our hospital, we have seen many people with just chronic frequent joint injections, joint intraarticular steroid injections, and they come to us with hypoadrenalism, right? So we are actually, if a patient has been on inhaled or topical steroids and they are hypotensive, we tend to have a low threshold for starting them on steroids, on straight dose of steroids. This is a classic Waterhouse-Friderichsen syndrome. We give them steroids. An interesting thing, many case reports of warfarin, patient of warfarin coming with hypotension and adrenal insufficiency because they have bled there, right? So there are certain criteria for actually giving steroids straight away in the ER. You don't have to wait until you do the test, right? It's important that whenever you have hyponatremia, you correct it very gently and you know, with close monitoring. Otherwise, you end up with actually with osmotic demyelination or central pontine analysis, which is fatal. Now, if I look at the complete, you know, some of the elements we have, you know, talked about. Now, the bedside clinical diagnosis acute adrenal crisis in this particular lady with hypotension, and critical osmotic hypotonic hyponatremia, right? She had acute adrenal crisis. The precipitant of the adrenal hypofunction is obviously chronic steroid use. Does she have an infection? I don't have any evidence that sepsis probably brought up the acute adrenal crisis, right? I don't have evidence, although I didn't. There was no procalcitonin or CRP just to have a feel whether she has sepsis, but the white count was normal, right? She has severe hypotonic hyponatremia, which is an emergency, and site of care obviously the ICU. She needed the antiemetics. You know, she should be put on the trembling position and giving boluses of normal saline followed by 3% saline, and she should have parenteral or straight doses of steroids. And we need actually input from ICU, endocrine, pulmonary, psychologist, educator. We need all these. Okay. As a matter of fact, her blood pressure improved quite well after the steroids, and her sodium also started to improve, right? So the team were actually happy, and that's why they presented it in the meeting. Otherwise, if they have failed to manage it properly, they wouldn't present in the meeting, right? So they did a great job, okay? Now, the last part is actually preparing for discharge, right? And this is the ACT scheme, which we tell people, okay, whenever you see a patient, you have to assess the response of the treatment, subjectively and objectively, and you have to put some criteria for discharge. And we tell them, try to put some criteria for discharge on the day of admission, so that you try to achieve them and discharge the patient earlier, right? And when you discharge them, don't forget to follow them up, right? And you know, I would have said that subjectively, she should have no more vomiting. She should not be confused, right? Objectively, her Glasgow Coma scale should be 15 out of 15. What are my criteria for discharge? A sodium of above 125, right? A blood pressure of above like this. I have to set criteria. A blood pressure of above 120, right? And I have to see them in clinic in a short while, right? Now, it is the end of the story, right? Now, this is a big, actually, in the morning meeting, then the debate came. Have we done our job, or are there other elements in the management that we have not actually touched on, right? And as a matter of fact, it was true that, yes, there were lots of other issues, several other issues actually, which were not touched on at all, right? Obviously, the teaching point in that morning meeting was to tell staff that you really have to practice all these seven golden steps to have a comprehensive package of acute management, right? But the important issue is, how can I help this patient actually stay well and not come to hospital again with an adrenal crisis, right? So this is what's called the advocacy oral munasara, right? As a matter of fact, this lady needed to have a self-management plan, so that, for example, if she's ill, what is she supposed to do with her steroid dose, right? Shall she increase them or double them or triple them, right? Another issue came up. She has osteoporosis, which we ought to take care of, right? She needs to have a steroid card. Now, a steroid card, what it does is, right, or a bracelet. Now, if she goes to see a doctor and the doctor says, I'm going to do surgery or whatever, she tells them, I have this card, and tell them this lady has hypoadrenalism. Please, perioperatively, for example, you have to provide for a steroid cover. And some people use a bracelet because they are afraid that if they are involved, for example, in a car accident and they are unconscious, right, people can tell okay, this patient has adrenal insufficiency, and we need to offer them steroid stress doses. So this was the end of my talk, and I hope actually I managed to share with you the important elements in acute care management, and the schemes that are important to have a better or high quality care.